Chapter 143. Spinal Cord. Introduction. Situation and extent. Spinal cord lies loosely in the vertebral canal. It extends from foramen magnum, where it is continuous with medulla oblongata, above and up to the lower border of first lumbar vertebra below. Coverings. Spinal cord is covered by sheaths called meninges, which are membranous in nature. Meninges are dura mater, pia mater, and arachnoid mater. These coverings continue as coverings of brain. Meninges are responsible for protection and nourishment of the nervous tissues. Shape and length. Spinal cord is cylindrical in shape. Length of the spinal cord is about 45 cm in males and about 43 cm in females. Enlargements. Spinal cord has two spindle-shaped swellings, namely cervical and lumbar enlargements. These two portions of spinal cord innervate upper and lower extremities respectively. Conus medullaris and filum terminal. Below the lumbar enlargement, spinal cord rapidly narrows to a cone-shaped termination called conus medullaris. A slender non-nervous filament called filum terminal extends from conus medullaris downward to the fundus of the dural sac at the level of second sacral vertebra. Segments. Spinal cord is made up of 31 segments, which are listed in box 143.1. In fact, spinal cord is a continuous structure. Appearance of the segment is by nerves arising from spinal cord, which are called spinal nerve. Spinal nerves. Segments of spinal cord correspond to 31 pairs of spinal nerves in a symmetrical manner. The spinal nerves are listed in box 143.1. Nerve roots. Each spinal nerve is formed by an anterior, ventral, root and a posterior, dorsal, root. Both the roots on either side leave the spinal cord and pass through the corresponding intervertebral foramina. The first cervical spinal nerves pass through a foramen between occipital bone and first vertebra, which is called atlas. Cervical and thoracic roots are shorter, whereas the lumbar and sacral roots are longer. Long nerves descend in dural sac to reach their respective intervertebral foramina. This bundle of descending roots surrounding the filum terminal resembles the tail of horse. Hence, it is called cauda equina. Fissure and sulci. On the anterior surface of spinal cord, there is a deep furrow known as anterior median fissure. Depth of this fissure is about 3 mm lateral to the anterior median fissure. On either side, there is a slight depression called the anterolateral sulcus. It denotes the exit of anterior nerve root. On the posterior aspect, there is a depression called posterior median sulcus. This sulcus is continuous with a thin glial partition called the posterior median septum. It extends inside the spinal cord for about 5 mm and reaches the gray matter. On either side, lateral to posterior median sulcus, there is posterior intermediate sulcus. It is continuous with posterior intermediate septum, which extends for about 3 mm into the spinal cord. Lateral to the posterior intermediate sulcus is the posterolateral sulcus. This denotes the entry of posterior nerve root. Internal structure of spinal cord. Neural substance of spinal cord is divided into inner gray matter and outer white matter, Fig 143.1. Gray matter of spinal cord. Gray matter of spinal cord is the collection of nerve cell bodies, dendrites, and parts of axons. It is placed centrally in the form of wings of the butterfly and it resembles the letter H. Exactly in the center of gray matter, there is a canal called the spinal canal. Ventral and the dorsal portions of each lateral half of gray matter are called ventral, anterior, and dorsal, posterior, gray horns respectively. In addition, the gray matter forms a small projection in between the anterior and posterior horns in all thoracic and first two lumbar segments. It is called the lateral gray horn. Part of the gray matter anterior to central canal is called the anterior gray commissure and part of gray matter posterior to the central canal is called posterior gray commissure. Neurons in gray matter of spinal cord. Gray matter contains two types of multipolar neurons, one Golgi type I neurons. Golgi type I neurons have long axons and are usually found in anterior horns. Axons of these neurons form the long tracts of spinal cord. Golgi type II neurons. Golgi type II neurons have short axons, which are found mostly in posterior horns. Axons of these neurons pass towards the anterior horn of same side or opposite side. Organization of neurons in gray matter. Organization of neurons in the gray matter of spinal cord is described in two methods, nuclei or columns. Laminae or layers, Fig 143.2. Nuclei. Clusters of neurons are present in the form of nuclei or cell columns in gray matter. Advantage of this method is that different nuclei are easily distinguished. Disadvantage is that some neurons like internuncial neurons, which are outside the distinct nuclei, are not included. Nuclei in posterior gray horn. Posterior gray horn contains the nuclei of sensory neurons, which receive impulses from various receptors of the body through posterior nerve root fibers. There are four types of nuclei of sensory neurons. Marginal nucleus. Marginal nucleus is also called posteromarginal nucleus, marginal zone nucleus or border nucleus. It covers the very tip of posterior gray horn and it is found in all levels of spinal cord. Substantia gelatinosa of Rolando. Substantia gelatinosa of Rolando is a cap-like gelatinous material at the apex of posterior horn situated in all levels of spinal cord. It is formed by small neurons. Chief sensory nucleus or nucleus proprius. Chief sensory nucleus is situated in the posterior gray horn ventral to substantia gelatinosa. It is a poorly defined cell column located in all segments of spinal cord. Dorsal nucleus of Clark. Clark nucleus is also called Clark column of cells and it is the collection of well-defined neurons. It occupies the basal portion of posterior horn. This nucleus is found in spinal segments between C8 and L3 only. Nuclei in lateral gray horn. Lateral gray horn has cluster of neurons called intermediolateral nucleus. The neurons of this nucleus give rise to sympathetic preganglionic fibers, which leave the spinal cord through the anterior nerve root. Intermediolateral nucleus extends between T1 and L2 segments of spinal cord. Nuclei in anterior gray horn. Anterior gray horn contains the nuclei of lower motor neurons, which are involved in motor function. These nuclei are present in almost all the levels of spinal cord. Three types of motor neurons are present in lower motor neuron nuclei: alpha motor neurons. Alpha motor neurons are large and multipolar cells. Axons of these neurons leave the spinal cord through the anterior root and end in groups of skeletal muscle fibers called extrafusal fibers. Gamma motor neurons. Gamma motor neurons are smaller cells scattered among alpha motor neurons. These neurons send axons to intrafusal fibers of the muscle spindle. Renshaw cells. These cells are also smaller in size. Renshaw cells are the inhibitory neurons, which play an important role in synaptic inhibition at the spinal cord, chapter 140. Laminae. Neurons of gray matter are distributed in laminae or layers. Each lamina consists of neurons of different size and shape. This cytoarchitectural lamination was identified in 1950 by Brian Burke and Rext. He classified the neurons in 10 laminae based on his observation on sections of brain in a neonatal cat. Laminae are also called Rext laminae. Advantage of this method is that all the neurons of gray horn are included. Disadvantage is that it is difficult to distinguish the laminae from one another. Laminae in posterior gray horn. Laminae I to 6 constitute the posterior gray horn. These laminae contain nuclei of sensory neurons, which are concerned with sensory functions. Nuclei present in the laminae of posterior gray horn. Marginal nucleus, lamina I substantial gelatinosa, laminae 2 and 3 of Rolando chief sensory nucleus, laminae 3, 4, and V dorsal nucleus of Clark, lamina 6 lamina in lateral gray horn. Lateral gray horn contains only one lamina, the lamina 7. It contains intermediolateral nucleus. Laminae in anterior gray horn. Laminae 8 and 9 form the anterior gray horn. These laminae contain nuclei of motor neurons, which are concerned with motor functions. Neurons present in the laminae of anterior gray horn. Motor internuncial neurons, lamina 8. Which are also called interneurons. Motor neurons, lamina 9. Lamina around central canal. There is only one lamina around the center of the spinal canal, the lamina X. It contains neuroglia, which form the supporting tissue. White matter of spinal cord. White matter of spinal cord surrounds the gray matter. It is formed by the bundles of both myelinated and non-myelinated fibers, but predominantly the myelinated fibers. Anterior median fissure and posterior median septum divide the entire mass of white matter into two lateral halves. The band of white matter lying in front of anterior gray commissure is called anterior white commissure, Fig 143.2. Each half of the white matter is divided by the fibers of anterior and posterior nerve roots into three white columns or funiculi, anterior or ventral white column. Ventral white column lies between the anterior median fissure on one side and anterior nerve root and anterior gray horn on the other side. It is also called anterior or ventral funiculus. Lateral white column. Lateral white column is present between the anterior nerve root and anterior gray horn on one side and posterior nerve root and posterior gray horn on the other side. It is also called lateral funiculus. Posterior or dorsal white column. Dorsal white column is situated between the posterior nerve root and posterior gray horn on one side and posterior median septum on the other side. It is also called posterior or dorsal funiculus. Tracts in spinal cord. Groups of nerve fibers passing through spinal cord are known as tracts of the spinal cord. The spinal tracts are divided into two main groups. They are, short tracts. Long tracts. Short tracts. Fibers of the short tracts connect different parts of spinal cord itself. Short tracts are of two types, association or intrinsic tracts, which connect adjacent segments of spinal cord on the same side. Commissural tracts, which connect opposite halves of same segment of spinal cord. Long tracts. Long tracts of spinal cord, which are also called projection tracts, connect the spinal cord with other parts of central nervous system. Long tracts are of two types, ascending tracts, which carry sensory impulses from the spinal cord to brain. Descending tracts, which carry motor impulses from brain to the spinal cord. Ascending tracts of spinal cord. Ascending tracts of spinal cord carry the impulses of various sensations to the brain. Pathway for each sensation is formed by two or three groups of neurons, which are, first-order neurons, second-order neurons, third-order neurons. First-order neurons. First-order neurons receive sensory impulses from the receptors and send them to sensory neurons present in the posterior gray horn of spinal cord through their fibers. Nerve cell bodies of these neurons are located in the posterior nerve root ganglion. Second-order neurons. Second-order neurons are the sensory neurons present in the posterior gray horn. Fibers from these neurons form the ascending tracts of spinal cord. These fibers carry sensory impulses from spinal cord to different brain areas below cerebral cortex, subcortical areas, such as thalamus. All the ascending tracts are formed by fibers of second-order neurons of the sensory pathways except the ascending tracts in the posterior white funiculus, which are formed by the fibers of first-order neurons. Third-order neurons. Third-order neurons are in the subcortical areas. Fibers of these neurons carry the sensory impulses from subcortical areas to cerebral cortex. Ascending tracts situated in different white funiculi are listed in Table 143.1 and their features are given in Table 143.2. 1. Anterior spinothalamic tract. Anterior spinothalamic tract is formed by the fibers of second-order neurons of the pathway for crude touch sensation, Figs 143.3 and 143.4. Situation. Anterior spinothalamic tract is situated in anterior white funiculus near the periphery. Origin. Fibers of anterior spinothalamic tract arise from the neurons of chief sensory nucleus of posterior gray horn, which form the second-order neurons of the crude touch pathway. First-order neurons are situated in the posterior nerve root ganglia. These neurons receive the impulses of crude touch sensation from the pressure receptors. Axons of the first-order neurons reach the chief sensory nucleus through the posterior nerve root. Course. Anterior spinothalamic tract contains crossed fibers. After taking origin, these fibers cross obliquely in the anterior white commissure and enter the anterior white column of opposite side. Here, the fibers ascend through other segments of spinal cord and brain stem, medulla, pons, and midbrain, and reach thalamus. Few fibers of this tract ascend in posterior gray horn for 2 or 3 segments in the same side and then cross over to the anterior white column of opposite side. While ascending through brain stem, the number of fibers is considerably reduced since some of the fibers form the collaterals and reach the reticular formation of brain stem. Termination. Fibers of anterior spinothalamic tract terminate in the ventral posterolateral nucleus of thalamus. Neurons of this thalamic nucleus form third-order neurons of the pathway. Fibers from thalamic nucleus carry the impulses to some aesthetic area, sensory cortex, of cerebral cortex. Function. Anterior spinothalamic tract carries impulses of crude touch, protopathic, sensation. Effect of lesion. Bilateral lesion of this tract leads to loss of crude touch sensation and loss of sensations like itching and tickling. Unilateral lesion of this tract causes loss of crude touch sensation in opposite side below the level of lesion, because fibers of this tract cross to the opposite side in spinal cord. 2. Lateral spinothalamic tract. Lateral spinothalamic tract is formed by the fibers from second-order neurons of the pathway for the sensations of pain and temperature, Fig 143.4. Situation. Lateral spinothalamic tract is situated in the lateral column towards medial side, i.e. near the gray matter. Origin. Fibers of lateral spinothalamic tract take origin from 2 sources, marginal nucleus. Substantia gelatinosa of Rolando. Course. Lateral spinothalamic tract has crossed fibers. Axons from marginal nucleus and substantia gelatinosa of Rolando cross to the opposite side and reach the lateral column of same segment. Few fibers may ascend 1 or 2 segments, then cross to the opposite side and then ascend in the lateral column. All the fibers pass through medulla, pons, and midbrain and reach thalamus along with fibers of anterior spinothalamic tract. Some of the fibers of lateral spinothalamic tract form collaterals and reach the reticular formation of brain stem. Fibers of lateral spinothalamic tract form spinal lemniscus along with the fibers of anterior spinothalamic tract at the lower part of medulla. Termination. Fibers of lateral spinothalamic tract terminate in the ventral posterolateral nucleus of thalamus along with anterior spinothalamic tract fibers. From here, third-order neuron fibers run to some aesthetic area, sensory cortex, of cerebral cortex. Function. Fibers of lateral spinothalamic tract carry impulses of pain and temperature sensations. Fibers arising from this marginal nucleus transmit impulses of fast pain sensation. Fibers arising from substantia gelatinosa of Rolando transmit impulses of slow pain and temperature sensations. Refer Chapter 145 for details of pain fibers. Effect of lesion. Bilateral lesion of this tract leads to total loss of pain and temperature sensations on both sides below the level of lesion. Unilateral lesion or sectioning of the lateral spinothalamic tract causes loss of pain, analgesia, and temperature, thermoanesthesia, below the level of lesion in the opposite side. 3. Ventral spinocerebellar tract. Ventral spinocerebellar tract is also known as Gower tract, indirect spinocerebellar tract or anterior spinocerebellar tract. It is constituted by the fibers of second-order neurons of the pathway for subconscious kinesthetic sensation, Fig 143.5. Situation. This tract is situated in lateral white column of the spinal cord along the lateral periphery. Origin. Fibers of this tract arise from the marginal nucleus in posterior gray horn. Neurons of marginal nucleus form the second-order neurons. Fibers from these neurons make their first appearance in lower lumbar segments of spinal cord. First-order neurons are in the posterior root ganglia and receive the impulses of proprioception from the proprioceptors in muscle, tendon, and joints. Fibers from neurons of posterior root ganglia reach the marginal cells through posterior nerve root. Course. Ventral spinocerebellar tract contains both crossed and uncrossed fibers. Majority of the fibers from the marginal nucleus cross the midline and ascend in lateral white column of opposite side. Some fibers ascend in the lateral white column of the same side also. These nerve fibers ascend through other spinal segments, medulla, pons, and midbrain. Finally, the fibers reach the cerebellum through the superior cerebellar peduncle. Termination. These fibers terminate in the cortex of anterior lobe of cerebellum. Function. Ventral spinocerebellar tract carries the impulses of subconscious kinesthetic sensation, proprioceptive impulses from muscles, tendons, and joints. Impulses of subconscious kinesthetic sensation are also called non-sensory impulses. Effect of lesion. Lesion of this tract leads to loss of subconscious kinesthetic sensation in the opposite side. 4. Dorsal spinocerebellar tract. Dorsal spinocerebellar tract is otherwise called flexig tract, direct spinocerebellar tract or posterior spinocerebellar tract. Like the ventral spinocerebellar tract, this tract is also constituted by the second-order neuron fibers of the pathway for subconscious kinesthetic sensation. The first-order neurons are in the posterior nerve root ganglia. But, the fibers of this tract are uncrossed, Fig 143.5. Situation. Dorsal spinocerebellar tract is situated in the lateral column along the posterolateral periphery of spinal cord. It is situated posterior to ventral cerebellar tract and anterior to the entry of posterior nerve root. Origin. Fibers of this tract originate from the dorsal nucleus of Clark situated in the posterior gray matter of the spinal cord. First appearance of the fibers is in upper lumbar segments. From lower lumbar and sacral segments, the impulses are carried upwards by dorsal nerve roots to upper lumbar segments. Course. Flexig tract is formed by uncrossed fibers. Axons from neurons in dorsal nucleus of Clark, second-order neurons, reach lateral column of same side. Then, these fibers ascend through other spinal segments and reach medulla oblongata. From here, the fibers reach cerebellum through inferior cerebellar peduncle. Termination. Fibers of this tract end in the cortex of anterior lobe of cerebellum along with ventral spinocerebellar tract fibers. Function. Along with ventral spinocerebellar tract, the dorsal spinocerebellar tract carries the impulses of subconscious kinesthetic sensation, which are known as non-sensory impulses. Effect of lesion. Unilateral loss of the subconscious kinesthetic sensation occurs in lesion of this tract on the same side, as this tract has uncrossed fibers. 5. Spinotectal tract. Spinotectal tract is considered as a component of anterior spinothalamic tract. It is constituted by the fibers of second-order neurons. Course. Flexig tract is formed by uncrossed fibers. Axons from neurons in dorsal nucleus of Clark, second-order neurons, reach lateral column of same side. Then, these fibers ascend through other spinal segments and reach medulla oblongata. From here, the fibers reach cerebellum through inferior cerebellar peduncle. Termination. Fibers of this tract end in the cortex of anterior lobe of cerebellum along with ventral spinocerebellar tract fibers. Function. Along with ventral spinocerebellar tract, the dorsal spinocerebellar tract carries the impulses of subconscious kinesthetic sensation, which are known as non-sensory impulses. Effect of lesion. Unilateral loss of the subconscious kinesthetic sensation occurs in lesion of this tract on the same side, as this tract has uncrossed fibers. 5. Spinotectal tract. Spinotectal tract is considered as a component of anterior spinothalamic tract. It is constituted by the fibers of second-order neurons. Situation. Spinotectal tract occupies the lateral side of lateral white column, anterior to lateral spinothalamic tract. It is bound anteriorly by anterior nerve root. Origin. Fibers of this tract originate from the chief sensory nucleus, like anterior spinothalamic tract. First appearance of the fibers is in upper lumbar segments. This tract is very prominent in the cervical segments. Course. Spinotectal tract contains crossed fibers. After taking origin, the fibers cross to opposite side through anterior white commissure to the lateral column. Then, these fibers ascend to the midbrain along with anterior spinothalamic tract. Termination. Fibers of spinotectal tract end in the superior colliculus of tectum in midbrain. Function. Spinotectal tract is concerned with spinovisual reflex. 6. Fasciculus Dorsolateralis. Fasciculus Dorsolateralis is otherwise called tract of Lissauer. It is considered as a component of lateral spinothalamic tract. And, it is constituted by the fibers of first-order neurons. Situation. Lissauer tract is situated in the lateral white column between the periphery of spinal cord and tip of posterior gray horn. Origin. Lissauer tract is formed by fibers arising from the cells of posterior root ganglia and enters the spinal cord through lateral division of posterior nerve root. Course. Lissauer tract contains uncrossed fibers. After entering spinal cord, the fibers pass upwards or downwards for few segments on the same side and synapse with cells of substantia gelatinosa of Rolando. Axons from these cells, second-order neurons, join the lateral spinothalamic tract. Function. Fibers of the dorsolateral fasciculus carry impulses of pain and thermal sensations. 7. Spinoreticular tract. Spinoreticular tract is formed by the fibers of second-order neurons. Situation. Spinoreticular tract is situated in anterolateral white column origin. Fibers of this tract arise from intermediolateral nucleus. Course. Spinoreticular tract consists of crossed and uncrossed fibers. After taking origin, some of the fibers cross the midline and then ascend upwards. Remaining fibers ascend up in the same side without crossing. Termination. All the fibers terminate in the reticular formation of brainstem by three ways. Some fibers terminate in nucleus reticularis gigantocellularis and lateral reticular nucleus of medulla in the same side. Some fibers terminate in the nuclei present in the opposite side. Some fibers terminate in nucleus reticularis pontis caudalis of the pons in the same side or opposite side. Very few fibers terminate in midbrain. Function. Fibers of the spinoreticular tract are the components of ascending reticular activating system and are concerned with consciousness and awareness. 8. Spinoolivary tract. Spinoolivary tract is situated in anterolateral part of white column. Origin of the fibers of this tract is not specific. However, the fibers terminate in olivary nucleus of medulla oblongata. From here, the neurons project into cerebellum. This tract is concerned with proprioception. 9. Spinovestibular tract. Spinovestibular tract is situated in the lateral white column of the spinal cord. Fibers of this tract arise from all the segments of spinal cord and terminate on the lateral vestibular nucleus. This tract is also concerned with proprioception. 10. Fasciculus gracilis, tract of Gall, N. 11. Fasciculus cuneatus, tract of Burdick. Fasciculus gracilis and Fasciculus cuneatus are together called ascending posterior column tracts. These tracts are formed by the fibers from posterior root ganglia. Thus, both the tracts are constituted by the fibers of first-order neurons of sensory pathway, Fig 143.6. Situation. Tracts of Gall and Burdick are situated in posterior white column of spinal cord, hence the name posterior column tracts. In the cervical and upper thoracic segments of spinal cord, the posterior white column is divided by posterior intermediate septum into medial fasciculus gracilis and lateral fasciculus cuneatus. Thus, The fasciculus gracilis is situated medially in between posterior median sulcus and posterior median septum on one side and posterior intermediate sulcus and posterior intermediate septum on the other side. Fasciculus cuneatus is situated laterally. It is bound medially by posterior intermediate septum and sulcus and laterally by posterior gray horn, tract of Lissauer and posterior nerve root. Origin. Fibers of these two tracts are the axons of first-order neurons. Cell body of these neurons is in the posterior root ganglia and their fibers form the medial division, bundle, of posterior nerve root. Course. After entering spinal cord, the fibers ascend through the posterior white column. These fibers do not synapse in the spinal cord. Some fibers of medial division of posterior nerve root descend through posterior white column in the form of fasciculus interfascicularis or tract of Schulze. Fasciculus gracilis contains the fibers from lower extremities and lower parts of the body, i.e. from sacral, lumbar, and lower thoracic ganglia of posterior nerve root. Fasciculus cuneatus contains fibers from upper part of the body, i.e. from upper thoracic and cervical ganglia of posterior nerve root. Termination. Tracts of Gall and Burdake terminate in the medulla oblongata. Fibers of Fasciculus gracilis terminate in the nucleus gracilis and the fibers of Fasciculus cuneatus terminate in the nucleus cuneatus. Neurons of these medullary nuclei form the second-order neurons. Axons of second-order neurons form the internal arcuate fibers. Internal arcuate fibers from both sides cross the midline forming sensory decussation and then ascend through pons and midbrain as medial lemniscus. Fibers of medial lemniscus terminate in ventral posterolateral nucleus of thalamus. From here, fibers of the third-order neurons relate to sensory area of cerebral cortex. Functions. Tracts of the posterior white column convey impulses of following sensations: fine, epicritic, tactile sensation. Tactile localization, ability to locate the area of skin where the tactile stimulus is applied with closed eyes. Tactile discrimination or trois-point discrimination, ability to recognize the two stimuli applied over the skin simultaneously with closed eyes. Sensation of vibration, ability to perceive the vibrations from a vibrating tuning fork placed over bony prominence conducted to deep tissues through skin. It is the synthetic sense, Chapter 144, produced by combination of touch and pressure sensations. Stereognosis, ability to recognize the known objects by touch with closed eyes. It is also a synthetic sense produced by combination of touch and pressure sensations. Effect of lesion. Lesion of nerve fibers in tracts of Gall and Burdake or lesion in the posterior white column leads to the following symptoms on the same side below the lesion: loss of fine tactile sensation, however, crude. Touch sensation is normal. Loss of tactile localization. Loss of two-point discrimination. Loss of sensation of vibration. Astereognosis, inability to recognize known objects by touch while closing the eyes. Lack of ability to differentiate the weight of different objects. Loss of proprioception, inability to appreciate the position and movement of different parts of the body. Sensory ataxia or posterior column ataxia, condition characterized by uncoordinated, slow, and clumsy voluntary movements because of the loss of proprioception. 12. Tract of Schulze. Tract of Schulze is also called Fasciculus interfascicularis. It is situated in between tracts of Gall and Burdake. This tract is formed by the short descending fibers, arising from the medial division of posterior nerve root. These fibers are also considered as the descending branches of the tracts of Gall and Burdake. Function of this tract is to establish intersegmental communications and to form short reflex arc. Descending tracts of spinal cord. Descending tracts of the spinal cord are formed by motor nerve fibers arising from brain and descend into the spinal cord. These tracts carry motor impulses from brain to spinal cord. Descending tracts of spinal cord are of two types: pyramidal tracts, extrapyramidal tracts. Descending tracts are listed in Table 143.3 and their features given in Table 143.4. Pyramidal tracts. Pyramidal tracts were the first tracts to be found in man. Pyramidal tracts of spinal cord are the descending tracts concerned with voluntary motor activities of the body. These tracts are otherwise known as corticospinal tracts. There are two corticospinal tracts, the anterior corticospinal tract and lateral corticospinal tract. While running from cerebral cortex towards spinal cord, the fibers of these two tracts give the appearance of a pyramid on the upper part of anterior surface of medulla oblongata, hence the name pyramidal tracts, Fig 143.7. Nerve fibers. All the fibers of the pyramidal tracts are present since birth. However, myelination of these fibers is completed in about 2 years after birth. The pyramidal tracts on each side have more than 1 million fibers. About 70% of the fibers are large myelinated fibers having a diameter of 4 to 22 micron. Large fibers of pyramidal tracts have the tendency to disappear at old age. Since these tracts are concerned with control of voluntary movements, the disappearance of the fibers of pyramidal tracts causes automatic shivering movements in old age. Fibers of pyramidal tracts are the axons of upper motor neurons. Origin. Fibers of pyramidal tracts arise from following cells or areas of cerebral cortex, giant cells or bed cells or pyramidal cells in precentral gyrus of the motor cortex. These cells are situated in area 4, primary motor area, of frontal lobe. Other areas of motor cortex, namely, premotor area, area 6, and supplementary motor areas. Other parts of frontal lobe. Somatosensory areas of parietal lobe. It is believed that 30% of pyramidal fibers arise from primary motor area, area 4, and supplementary motor areas, another 30% from premotor area, area 6, and the remaining 40% of fibers arise from somatosensory areas. All the above fibers form fibers of upper motor neurons of motor pathway. Course. Corona radiate. After taking origin, the nerve fibers run downwards in a diffused manner through white matter of cerebral hemisphere and converge in the form of a fan-like structure along with ascending fibers, which project from thalamus to cerebral cortex. This fan-like structure is called corona radiata. Thus, corona radiata contains both ascending fibers from thalamus and descending fibers from cerebral cortex. Internal capsule. While passing down towards the brainstem, the corona radiata converges in the form of internal capsule. It is situated in between thalamus and caudate nucleus on the medial side and lenticular nucleus on the lateral side, chapter 148. In pons. The fibers descend down through internal capsule, midbrain, and pons. While descending through pons, the fibers are divided into different bundles by the nuclei of pons. At lower border of pons, the fibers are grouped once again into a compact bundle and then descend down into medulla oblongata. In medulla, this compact bundle of corticospinal fibers gives the appearance of a pyramid in the anterior surface of upper part of medulla. So, the corticospinal tracts are called the pyramidal tracts. At the lower border of medulla, pyramidal tract on each side is divided into two bundles of unequal sizes. About 80% of fibers from each side cross to the opposite side. While crossing the midline, the fibers of both sides form the pyramidal decussation. In spinal cord, fibers which cross the midline and form pyramidal decussation descend through posterior part of lateral white column of spinal cord. This bundle of crossed fibers is called the crossed pyramidal tract or lateral corticospinal tract or indirect corticospinal tract. Remaining 20% of fibers do not cross to the opposite side but descend down through the anterior white column of the spinal cord. This bundle of uncrossed fibers is called the uncrossed pyramidal tract or anterior corticospinal tract or direct corticospinal tract. This tract is well marked in cervical region. Since the fibers of this tract terminate in different segments of spinal cord, this tract usually gets thinner while descending through the successive segments of spinal cord. Fibers of this tract are absent mostly below the mid-thoracic level. Before termination, majority of the fibers of this anterior corticospinal tract cross to the opposite side at different levels of spinal cord. Termination. All the fibers of pyramidal tracts, both crossed and uncrossed fibers, terminate in the motor neurons of anterior gray horn either directly or through internuncial neurons. Pyramidal tract fibers terminate on both alpha motor neurons and beta motor neurons. Axons of the motor neurons leave the spinal cord as spinal nerves through anterior nerve roots and supply the skeletal muscles. Neurons giving origin to the fibers of pyramidal tract are called the upper motor neurons. Anterior motor neurons in the spinal cord are called the lower motor neurons. Function. Pyramidal tracts are concerned with voluntary movements of the body. Fibers of the pyramidal tracts transmit motor impulses from motor area of cerebral cortex to the anterior motor neurons of the spinal cord. These two tracts are responsible for fine, skilled movements. Effects of lesion. Lesion in the neurons of motor cortex and the fibers of pyramidal tracts is called the upper motor neuron lesion. In human beings, pure pyramidal tract lesions do not occur. Lesion of pyramidal fibers occurs most commonly in stroke, cardiovascular accident, due to hemorrhage and thrombosis. During such lesions, many extrapyramidal fibers are also damaged along with pyramidal fibers. Because of this reason, neurologists often consider the lesion as upper motor neuron lesion and not as pyramidal tract lesion. Following are the effects of lesion. Voluntary movements. Voluntary movements of the body are very much affected. Initially, there is loss of voluntary movements in the extremities. Later, it involves the other parts of the body like hip and shoulder. Muscle tone. Muscle tone is increased leading to spasticity. Muscles are also paralyzed. This type of paralysis of muscles is called the spastic paralysis. The spasticity is due to the failure of inhibitory impulses from upper motor neurons, particularly the neurons of extrapyramidal system to reach the gamma motor neurons in spinal cord. However, hypotonia occurs in pure pyramidal tract lesion, which is very rare. In monkeys, sectioning of pyramidal tract fibers alone results in hypotonia. Reflexes. All the superficial reflexes are lost and the deep reflexes are exaggerated. Abnormal plantar reflex called Babinski sign is present, Babinski sign positive. More details of upper motor neuron lesion are given in the next chapter. Effects of lesion at different levels. Cerebral cortex. Lesion of pyramidal tract fibers in cerebral cortex causes hypertonia, spasticity and contralateral monoplegia, paralysis of one limb, or contralateral hemiplegia, paralysis of one side of the body. Internal capsule. Lesion of pyramidal tract fibers at posterior limb of internal capsule results in contralateral hemiplegia. Brainstem. Lesion at brainstem involves not only pyramidal tract fibers but also other structures such as 6 and 7 cranial nerve nuclei. So the lesion results in contralateral hemiparesis, weakness of muscles in one side of the body, along with 6 and 7 cranial nerve palsies. Spinal cord. Unilateral lesion of lateral corticospinal fibers at upper cervical segment causes ipsilateral hemiplegia and bilateral lesion causes quadriplegia, paralysis of all four limbs, and paralysis of respiratory muscles. Bilateral lesion of these fibers in thoracic and lumbar segments results in paraplegia, paralysis of both lower limbs, without paralysis of respiratory muscles. Extrapyramidal tracts. Descending tracts of spinal cord other than pyramidal tracts are called extrapyramidal tracts. Extrapyramidal tracts are listed in Table 143.3. 1. Medial longitudinal fasciculus. Situation. Medial longitudinal fasciculus descends through posterior part of anterior white column of the spinal cord. Origin. Actually, this tract is the extension of medial longitudinal fasciculus of brainstem. Fibers of this tract take origin from 4 different areas in brainstem: vestibular nuclei, reticular formation, superior colliculus, interstitial cells of Kajal. Course. After entering the spinal cord from the brainstem, the fibers of medial longitudinal fasciculus descend through posterior part of anterior white column of the same side. In the spinal cord, This tract is well defined only in upper cervical segments. Below this level, the fibers run along with the fibers of anterior vestibulospinal tract. Extent. Fibers of this tract extend up to the upper cervical segments of spinal cord. Termination. Fibers of this tract terminate in anterior motor neurons of the spinal cord along with fibers of anterior vestibulospinal tract either directly or through internuncial neurons. Function. Medial longitudinal fasciculus helps in the coordination of reflex ocular movements and the integration of ocular and neck movements. Effects of lesion. Reflex ocular movements and reflex neck movements are affected in the lesion of this tract. 2. Anterior vestibulospinal tract. Situation. Anterior vestibulospinal tract is situated in the anterior white column, along the periphery of spinal cord lateral to tectospinal tract. Origin. Fibers of this tract arise from medial vestibular nucleus in medulla oblongata. In fact, anterior vestibulospinal tract is the extension of medial longitudinal fasciculus. Most of the fibers are uncrossed. Extent. Fibers run up to thoracic segments of spinal cord. Course. Fibers of this tract run down from medulla into the anterior column of spinal cord along the periphery. All the fibers are uncrossed. Termination. Along with fibers of lateral vestibulospinal tract, the fibers of this tract terminate in anterior motor neurons directly or through internuncial neurons. Function. Function of this tract is explained along with the function of lateral vestibulospinal tract. 3. Lateral vestibulospinal tract situation. Lateral vestibulospinal tract occupies the anterior part of lateral white column of spinal cord. Origin. Fibers of this tract take origin from the lateral vestibular nucleus in medulla. This nucleus is also called dura nucleus. Extent. Fibers of this tract are present throughout the spinal cord. Course. From dura nucleus, most of the fibers descend directly through lateral column. Very few fibers cross to the opposite side before descending. Termination. Fibers of this tract terminate in the anterior motor neuron, either directly or via internuncial neurons. Functions. Vestibular nuclei receive impulses concerned with muscle tone and posture from vestibular apparatus and cerebellum. Vestibular nuclei in turn convey the impulses to different parts of the body through the anterior and lateral vestibulospinal tracts. Vestibulospinal tracts are concerned with adjustment of position of head and body during angular and linear acceleration. Effect of lesion. Adjustment of head and body becomes difficult during acceleration when the vestibulospinal tracts are affected by lesion. 4. Reticulospinal tract. Situation. Reticulospinal tract is situated in the anterior white column, posterior to anterior vestibulospinal tract. Origin. Fibers of this tract arise from the reticular formation of pons and medulla. Pontine reticular fibers are uncrossed, direct, and descend in medial part of anterior column. Fibers from medullary reticular formation are predominantly uncrossed and only few fibers are crossed. These fibers descend in lateral part of anterior column and to some extent in the anterior part of lateral column. Extent. Fibers of reticulospinal tract extend up to thoracic segments. Termination. Fibers of reticulospinal tract terminate in gamma motor neurons of anterior gray horn through the internuncial neuron. Functions. Reticulospinal tract is concerned with control of movements and maintenance of muscle tone, respiration, and diameter of blood vessels. Pontine and medullary fibers have opposite effects on these functions, which are given in Table 143.5. Effect of lesion. Lesion of reticulospinal tract causes disturbances in respiration, blood pressure, movements of body and muscle tone. 5. Tectospinal tract. Situation. Tectospinal tract is situated in the anterior white column of spinal cord. Origin. Nerve fibers of this tract arise from superior colliculus of midbrain. Extent. Tectospinal tract extends only up to lower cervical segments. Course. After taking origin from superior colliculus, the fibers cross the midline in dorsal tegmental decussation and descend in anterior column. Termination. Fibers of tectospinal tract terminate in the anterior motor neurons of spinal cord, directly or via internuncial neurons. Function. Tectospinal tract is responsible for the movement of head in response to visual and auditory stimuli. 6. Rubrospinal tract. Situation. Rubrospinal tract is situated in the lateral white column of spinal cord. Origin. Fibers of this tract arise from large cells, nucleus magnocellularis, of red nucleus in midbrain. Extent. Nerve fibers of this tract appear in the spinal cord only up to thoracic segments. Course. After arising from the red nucleus, the fibers cross the midline in ventral tegmental decussation and descend into spinal cord through the reticular formation of pons and medulla. Termination. Fibers of rubrospinal tract end in the anterior motor neurons of the spinal cord via internuncial neurons. Function. Rubrospinal tract exhibits facilitatory influence upon flexor muscle tone. 7. Olivospinal tract. Situation. Olivospinal tract is present in lateral white column of spinal cord. Origin. The nerve fibers of the olivospinal tract take origin from the inferior olivary nucleus, which is present in the medulla oblongata. Termination. Fibers of this tract terminate in the anterior motor neurons of spinal cord. Function. Functions of the olivospinal tract are not known clearly. It is believed that this tract is involved in reflex movements arising from the proprioceptors. Applied physiology. Spinal cord injury leads to either temporary or permanent dysfunction. Dysfunction of spinal cord occurs because of direct injury due to bullet firing or accidents, on road, in working place, during communal violence, etc. Compression by bone fragments, hematoma, or disc material. Ischemia due to rupture of spinal arteries. During mechanical injury, spinal cord may be cut into two or one lateral half of the spinal cord may be damaged or diffused. Crushing of several segments of spinal cord may also occur. Accordingly, dysfunction of spinal cord is classified into four types: complete transaction, incomplete transaction, hemisection. Diseases of spinal cord. Complete transection of spinal cord. Complete transection of spinal cord occurs due to bullet injury, which causes dislocation of spinal cord, accidents, which cause dislocation of spinal cord or occlusion of blood vessels. Complete transection causes immediate loss of sensation and voluntary movement below the level of lesion. In quick transection of spinal cord, the patient feels himself cut into two. For a while, his mind remains clear, but he feels as if his lower part of the body below the injury does not exist. It is because his higher centers remain unaffected but the spinal centers below the level of injury lose the function. Then the effects, symptoms, of complete transection of spinal cord start appearing. Effects occur in three stages: stage of spinal shock, stage of reflex activity, stage of reflex failure, stage of spinal shock. Stage of spinal shock is the first stage of effects that occurs immediately after injury. It is also called stage of flaccidity. Following are the signs and symptoms that develop during this stage: paralysis of limbs. Paralysis occurs in two limbs or in all four limbs. Paralysis of limbs depends upon the level of injury. Injury at the cervical region of the spinal cord leads to the paralysis of all the four limbs. Paralysis of all the four limbs is called quadriplegia or tetraplegia. Injury at the thoracic, lumbar, or sacral segments including cauda equina and conus medullaris causes paralysis of lower limbs. Paralysis of lower limbs is called paraplegia. Flaccid paralysis. Paralyzed muscles become flaccid, i.e. lose stiffness because of loss of tone. This type of paralysis is called flaccid paralysis. Loss of reflexes. All the reflexes are lost because of the injury to anterior and posterior nerve roots. Loss of sensations. All the sensations are lost because of the injury to posterior nerve roots and sensory neurons in the posterior gray horn. Effect on visceral organs. Some of the visceral organs are also affected, especially, urinary bladder and rectum are paralyzed. Heart rate. Heart rate is decreased and pulse becomes weak and thready. Venous return. Venous return is very much decreased. Venous return depends upon the muscle tone during resting condition. During activity it depends upon contraction of skeletal muscle, muscle pump, refer to chapter 98. But, in complete transection of spinal cord, muscle tone is lost and flaccid paralysis occurs. This leads to decrease in venous return. In addition, the limbs are immobile and smooth muscles of blood vessels lose the tone. So, the blood gets accumulated in blood vessels of limbs, particularly in lower limbs. And, the lower limbs become cold and blue. Effect on blood pressure. Effect on blood pressure depends upon the level of injury, lesion anywhere below L2 segment. Blood pressure is not affected much because the sympathetic vasoconstrictor fibers leave the spinal cord between T1 and L2 segments. Lesion at or above T1 segment. All the sympathetic vasoconstrictor fibers leaving the spinal cord from T1 and L2 segments are transect and are completely cut off from higher medullary cardiovascular centers, which regulate the blood pressure. So the blood pressure falls drastically. Mean arterial pressure falls below 40 mm Hg. Severity of complete transection depends upon the level of lesion. Complete transection at the level of cervical region can be very fatal. Because, the diaphragm and other respiratory muscles are cut off from respiratory centers. It causes paralysis of respiratory muscles leading to sudden arrest of breathing. The crushing injury at sacral segments of spinal cord results in atonic bladder and loss of micturition reflex, chapter 57. In human beings, the stage of spinal shock lasts for about 3 weeks. In animals the duration of spinal shock varies in different species. In amphibians like frog, it lasts only for few minutes. In mammals like dogs and cats, it lasts for few hours. In monkeys, it lasts for few days. Stage of reflex activity. Stage of reflex activity is also called stage of recovery. After 3 weeks period, depending largely upon the general health of the patient, the reflex activity begins to return to the isolated segments of spinal cord below the level of lesion. Developments taking place in this stage. First, the functional activities return to smooth muscles. Next, the sympathetic tone to blood vessels returns. As the neurons in gray horn act independently of vasomotor center, the tone in blood vessels is restored and the blood pressure is also restored to its normal level. Lastly, after another 3 months, the tone in skeletal muscle returns. Tone returns to flexor muscles first. So, the flexor muscles of lower limb become less flabby and offer some resistance to the toes. Though the tonicity is returned, it is not complete even in flexor muscles. So, the muscles remain hypotonic. Limbs in this condition tend to adopt a position of slight flexion and the paralysis is therefore called the paraplegia in flexion. Limbs cannot support weight of the body. After few weeks, when tone returns to more muscles, reflex movements can occur. Flexor reflexes appear first. To elicit the flexor reflex, a painful stimulus is required. First reflex, which usually appears, is the Babinski reflex. After a variable period of 1 to 5 weeks of reappearance of flexor reflexes, the extensor reflexes return. Initially, knee jerk returns and then the ankle jerk. In some cases, a widespread reaction can be elicited by scratching the skin over the lower limbs or the anterior abdominal wall, depending upon the level of lesion. This reaction constitutes the spasm in flexor muscles of both the lower limbs, evacuation of urinary bladder and profuse sweating. This is known as the mass reflex. Stage of reflex failure. Though the reflex movements return, muscles below the level of injury have less power and less resistance. Usually, general condition of the patient starts deteriorating. General infection or toxemia becomes common. Due to this, the failure of reflex function develops. The reflexes become more difficult to elicit. The threshold for stimulus increases. Mass reflex is abolished and the muscles become extremely flaccid and undergo wasting. Incomplete transection of spinal cord. If spinal cord is gravely injured, but does not suffer complete division, the condition is called as incomplete transaction. Symptoms of incomplete transection. After incomplete transection of the spinal cord, all the three stages of complete transection occur. Stage of spinal shock. Stage of reflex activity. Stage of reflex failure. Stage of spinal shock. Features are similar to those of complete transaction. Stage of reflex activity. Features of this stage: tone returns to extensor muscles first and not to the flexor muscles. This is because, in incomplete transection, some of the descending fibers in lateral column of cord, especially vestibulospinal and reticulospinal tracts, may escape the injury. So, some connections persist between brainstem and spinal cord. Fibers of vestibulospinal and reticulospinal tracts mainly reinforce the activity of extensor motor neurons. Because of this, there is extensor hypertonia, and so, the lower limbs are extended at hip and knee with toes pointing slightly downwards. This condition is known as paraplegia in extension. Stretch reflex reappears first. Flexor reflexes return later. Phillips-Son reflex, clasp knife reflex, can be elicited. In the upper limb, some resistance is offered when the arm is flexed at elbow joint passively. That is, the arm cannot be flexed. This resistance is offered because of the stretch reflex developed in the triceps muscle. However, if forearm is flexed forcefully, the resistance to flexion is abolished suddenly, leading to quick flexion of arm. This is called the Phillips-Son reflex or clasp knife reflex. Mass reflex, which is produced in complete transection, does not occur in incomplete transection of spinal cord. Stage of reflex failure. Features are similar to those of complete transection. Hemisection of spinal cord, Brown-Séquard syndrome. Lesion involving one lateral half of the spinal cord is called hemisection, Fig 143.8. It can occur due to injury during accidents. It can also be produced experimentally in animals. Symptoms of hemisection of spinal cord. Signs and symptoms, which occur after hemisection of the spinal cord, constitute Brown-Séquard syndrome. If the hemisection is due to injury, spinal shock occurs immediately. Muscles lose the tone and become flaccid. The reflexes are abolished. In case the patient survives, this stage gradually passes off and certain signs and symptoms develop. Effects are seen below the level of lesion and at the level of lesion. Effects in these areas differ on the same side and opposite side. There are changes in sensory and motor functions. Effects of hemisection of spinal cord below the level of lesion on the same side. Sensory changes. On the same side below the level of lesion, following sensations are lost because these sensations are carried by the uncrossed fibers of tracts of gall and bird ache, fine touch. Tactile localization. Tactile discrimination. Sensation of vibration. Conscious kinesthetic sensation. Stereognosis. Some sensations are not affected because these sensations are carried by crossed fibers of spinothalamic tracts. These sensations are: crude touch, pain, temperature. Motor changes. Motor changes resemble the effects of upper motor neuron lesion, Chapter 144. Muscle tone increases, leading to spastic paralysis. Rigidity of limbs occurs. Muscle wastage does not occur. Superficial reflexes are lost. Babinski sign is positive. Deep reflexes are exaggerated. Fall in blood pressure because of loss of vasomotor tone. On the opposite side. Sensory changes on the opposite side, below the level of lesion, the following sensations are lost completely because these sensations are carried by crossed spinothalamic tracts: crude touch. Pain. Temperature. Following sensations are not affected because, these sensations are carried by uncrossed tracts of gall and bird-ache, fine touch. Tactile localization. Tactile discrimination. Sensation of vibration. Conscious kinesthetic sensation. Stereognosis. Motor changes. Mostly there may not be any paralysis of muscles. If it occurs, it would be mild as only a few fibers of pyramidal tract are affected. This is because pyramidal fibers cross to the opposite side. Paralysis is of upper motor neuron lesion type. Thus, during hemisection of spinal cord, motor loss is extensive and sensory loss is less below the level of lesion on the same side. On the opposite side, sensory loss is extensive and motor loss is less. Effects of hemisection of spinal cord at the level of lesion. On the same side. Sensory changes. On the same side at the level of hemisection, there is complete anesthesia. That is, all the sensations are lost, table 143.6. This is because of complete destruction of the posterior nerve root. Motor changes. Effects of lower motor neuron lesion occur because the motor neurons and their fibers leaving the spinal cord are affected. Motor changes of lower motor neuron lesion are, muscles lose the tone and become flaccid and paralyzed. This type of paralysis with loss of muscle tone is called flaccid paralysis. All the reflexes are lost. Muscles degenerate and undergo wasting due to loss of tone. Vasomotor tone is lost. On the opposite side. Sensory changes. There is loss of pain, temperature, and crude touch sensations because the crossed spinothalamic tracts are affected but tracts of gall and bird-ache are not affected. So, the sensations carried by these two tracts are not affected. Motor changes. No motor change occurs. If it occurs, it is very mild and is similar to the effects of lower motor neuron lesion, chapter 144. Diseases of spinal cord. Syringomyelia. Syringomyelia is spinal cord disorder characterized by the presence of fluid-filled cavities in the spinal cord. Gray matter around the central canal is the most affected part. So the sensory disturbances are more pronounced than the motor disturbances. Cause. Syringomyelia occurs due to the overgrowth of neuroglial cells in spinal cord accompanied by cavity formation and accumulation of fluid. Initially, a cavity appears in gray matter near the central canal of spinal cord. In later stages, the cavity extends and involves the surrounding white matter to a variable degree. The disease usually starts in one or two segments. Then, it extends up and down for considerable distances. Lower cervical and upper thoracic regions are affected the most. Features. Characteristic features of this disease are the loss of pain and temperature sensations and muscular weakness. Severity of the loss of sensations depends upon the extent of disease in spinal cord. Symptoms of syringomyelia: if disease is only around central canal, there is loss of temperature, pain, and crude touch sensations only. It is due to lesion of the fibers crossing through the anterior gray commissure. Fine touch sensation is not affected because the fibers of fine touch pathway are in the posterior white column. If lesion is unilateral, effect occurs only on the same side. If disease extends to posterior gray horn, all the sensations are lost. Due to loss of pain and temperature sensations, the affected part is not withdrawn either reflexly or consciously from a painful stimulus. So, the affected persons become prone for injuries. Since the injury is not perceived, it leads to severe damage to the tissues. If anterior gray horn is affected, there is flaccid paralysis of muscles. In later stages, both pyramidal and extrapyramidal tracts are also involved, if the disease spreads to white matter. It causes spastic paralysis of limbs, especially in lower limbs, resulting in spastic paraplegia. Weakness and wasting of small muscle of limbs occur. Winging of scapula and scoliosis, lateral curvature of spine, develops. Tabes dorsalis. Tabes dorsalis is another disease of the spinal cord. It is a slowly progressive nervous disorder affecting both the motor and sensory functions of spinal cord. Cause. It occurs due to the degeneration of posterior, sensory, nerve roots. It usually occurs in syphilis. Posterior nerve roots are affected proximal to the posterior root ganglia. Ganglia are not affected. Among the fibers of posterior root, the fibers of lateral division are affected much. Reason for this type of selective degeneration is not known. Along with lateral fibers of posterior root, the fibers in posterior white column of spinal cord are also affected. Features. In tabs dorsalis, both sensory and motor functions are affected. Following are the features, sensations. During the onset of degenerative changes, there is exaggeration of pain sensation. Then, there is impairment and loss of all sensations. Loss of sensations, particularly pain sensation, leads to deformities of joint. There is no proper support and movements at the joints become uncontrolled. It is called Charcot joint. Joints enlarge due to inflammation by the development of osteoarthritis. Reflexes. Both superficial and deep reflexes are lost in tabs dorsalis mostly because of loss of sensations. Voluntary movements. There is lack of coordination of movements, ataxia. Normal movements like walking also become clumsy. The gait is awkward. Every movement of the limb is exaggerated while walking. Patient keeps the leg apart, raises the leg very high and stamps it down forcibly. This is called stamping gait. Urinary bladder. If sacral segments are affected in tabs dorsalis, the smooth muscles of the urinary bladder become hypotonic. Micturition reflexes are lost. And the urinary bladder becomes atonic bladder, chapter 57. Multiple sclerosis. Multiple sclerosis, MS, is a chronic and progressive inflammatory disease characterized by demyelination in brain and spinal cord. It affects the myelinated nerve fibers of brain, spinal cord, and optic nerve and causes gradual destruction of myelin sheath, demyelination. When the disease progresses, there is transection of axons in patches throughout brain and spinal cord. The term sclerosis refers to scars, scleroses, in the myelin sheath. Cause. Cause of multiple sclerosis is unknown. It is hypothesized that multiple sclerosis occurs due to combination and interaction of environmental factors, chemicals, bacteria, and virus, and genetic factors resulting in abnormal reactions of immune system. During the process, the immune system attacks the myelin sheath. Signs and symptoms. Initial attack by multiple sclerosis is often mild or asymptomatic. As the disease progresses, variety of symptoms start appearing. Symptoms become severe during further progress of the disease. Common initial symptoms: mild disturbance in the sensations on face, arms, and legs. Weakness and disturbances in maintenance of posture. Double vision followed by partial blindness. Other symptoms when the disease progresses: tremor, fatigue, and muscle spasms. Speech difficulty. Difficulty in performing day-to-day activities. Bowel problems. Bladder dysfunction. Emotional outbursts like anxiety, anger, and frustration. Short-term memory loss. Complete blindness. Development of suicidal tendency. Disc prolapse. Intervertebral or spinal disc is the cartilaginous structure of vertebral column that separates each vertebra. It is made up of a tough outer fibrous layer and a soft inner part. Inner part acts as a shock absorber and cushions the vertebrae while moving. A small gap in between the adjacent vertebrae allows nerve roots to enter or leave the spinal cord. Rupture of disc is called disc prolapse. During disc prolapse, the soft inner material bulges out through a weak area in the hard outer layer. The bulged disc material may irritate or compress or damage the nerve root that passes through the gap between the vertebrae. Severity of the condition depends upon the degree of bulging. Causes: injury to spinal cord, neck, or back. Heavy weight lifting. Sitting for a long time. Sudden violent twisting of the body involving spine. Aging, because of gradual degeneration of disc with age. After about 30 years of age, the disc starts dehydrating. So it is more susceptible for rupture at the age of 30 to 40 years. Symptoms. Symptoms of disc prolapse include pain and weakness in the area of prolapse. Most common area of disc prolapse is the lower part of vertebral column. If it compresses the sciatic nerve, the symptoms become more severe. Pain spreads down the back of leg to ankle, heel, or toes of foot. Lower limb cannot be lifted sometimes. There is numbness and tingling in the affected region. Sitting for long period aggravates the pain and develops other symptoms such as sneezing, coughing, or voiding of urine. Prolonged compression of sciatic nerve leads to weakness of leg muscles. Next common area of disc prolapse is the neck. In this case, the pain is felt in neck, shoulder blade, and armpit. If the nerves supplying upper limbs are compressed, the pain spreads through the arm up to the fingers. It also causes stiffness, weakness, or tingling in the upper limbs. Even the movements of fingers or arm are restricted.